Fine. Hi, Mona. Shall we make a start? I think it's 2:04. I think we'll make a start. I think few people have joined. We'll make a start. Hi, everyone. Welcome to the Friday NeoFOCUS 2 p.m. webinar. Today we have a case presentation from Dr. Mona Noureldein. She is one of my consultant colleague. I know Mona for a while, I know for many years now, 8, 9 years. She was my reg in Luton and she was in Heartlands as my reg. After CCT, she went to Canada to do a fellowship in neonatal medicine, Ottawa, and she came back as my consultant colleague. She's very much enthusiastic about hemodynamics and POCUS, and I'm looking forward for her interesting case presentation. Thanks, Mona. Stage is all yours.
Okay, thanks, Harsha, for the introduction. Shall I share my screen? All right. All right. Do you see my screen?
Yeah, I can see.
And do you hear?
Thank you.
And you hear me? Okay, that's fine. All right.
I can hear you. Yeah.
Perfect. So, thank you guys for coming in to listen to my talk. Today, I have no conflict of interest actually, and then today, I'll be talking about a case of systemic hypertension. Then I'll be talking about the background and the underlying pathology of that condition. Then I'll explain a couple of points in the hemodynamics of this condition as well. So first is our case. We have here a 35 plus 5 weeks baby who is a bit biggish. When I first saw her, I thought she probably is an infant of diabetic mother, but there was no history of that in mom's history. And after asking her, parents are consanguineous and they have bad obstetric history. She was born in good condition, but was admitted to the neonatal unit, our neonatal unit, at 20 minutes of life due to tachypnea, desaturation, and fever. So this was the, as usual, the baby was put on low flow oxygen and we did an X-ray at 4 hours of life. I just want to move that one. And so as you can see from the X-ray, anybody want to say anything or write on the chat? Harsha will keep an eye on it. So the heart looks big and the lungs are streaky and still looks like an infant of diabetic mother's X-ray. So, but again, there's no history. She had a acceptable, this is her first gas, was acceptable with a bit of lactate and base excess of -8. But her first CRP was surprisingly very high, 231. So she was already on bimpen and gent. Had a lumbar puncture the following day. But later on the culture did not grow anything and was treated for meningitis. On day 2, actually day 1, day 2, she had a high potassium level, but the samples, I thought it was problems of the samples. This baby was very irritable. Each time you try to touch her, she was agitated. So I received 1 dose of salbutamol, but said, okay, shall we insert a UAC because this baby is very difficult. And we inserted the UAC and the potassium surprisingly was normal. And then we monitored her blood pressure. So you can see her non-invasive blood pressure was normal. And then surprisingly, we looked at her systolic blood pressure consistently was very, very high. Her diastolic blood pressure was not very bad, actually was almost normal. But the systolic blood pressure is significantly high. This is her centiles as per Zubro et al. We use this around here. We try. So her 95th centile is 48 and she was way above 100, and her diastolic blood pressure is actually probably between 50th, just above 50th centile. So yeah, this is a case of hypertension, systolic hypertension. So we thought at that point the baby is probably behaving like meningitis, probably autonomic dysregulation, and this is the cause of her hypertension. And she has never had a normal lactate. Her lactate, as you can see, the trend here has never been normal until day 2. She had this lactate and said, okay, this baby has a big heart and she has pulmonary hypertension, a big heart on the x-ray, I mean, and she has systemic hypertension. So I'm going to do an echo on her. So I did an echo, and as you can see, I have quite few images. If somebody wants to say anything, just please say or write, and Harsha will let me know. So here in the subcostal view, you can see that the IVC is a bit dilated. She was self-ventilating her air at that point. This means there is increased RA pressure. And then I looked at her aorta while I was in the subcostal view. I thought, this aorta looks a bit weird, it's a bit smallish and not pulsatile that much. But the baby had postductal hypertension, is unlikely to be problem with the aorta, is unlikely to be coarctation. And also these images were reviewed by cardiology later on. They were not concerned about it, about the aorta. All right, so, and then this is the her interatrial communication. You can see there is some bidirectional flow, mainly left to right, is here on the Doppler as well. So there's some sort of increased pulmonary artery pressure as well. Then looked at her apical views. Here, the heart was actually, it seemed to be worse on our echo machine, because our echo is designed to save 3 seconds only and keeps repeating. It is worse. It was worse on the echo machine. So yeah, but the systolic function of the LV was also impaired. You can see it's also, you can appreciate it here, but by biplane ejection fraction was 31%. And here, I don't know, I tried to open this tricuspid valve, I couldn't, and it looks bright as well, and I couldn't open. But when I Dopplered, there was TR, and it was almost, it's not a complete envelope here, but it's more than 3 meters. And the cardiologist had the same impression that it's okay, they can see the TR. And then here also the right side was a bit, the left side has probably there is an MR more than 4 meters per second, which means probably the LV is under strain, probably because of the systemic hypertension. The tissue Doppler of the LV, I just focused on the LV. I didn't get the RV here, but the S prime systolic function was impaired on the lateral and septal. As you can see, 0.03 meters per second is very low, but the cardiac output was acceptable at that point. But her heart rate, probably she was crazy on me. Her heart rate was between 150 and 160 during the echo. So so I think this probably the compensation for her cardiac output. The RV function also seemed to be impaired. This is the RV 3-chamber view. You can see it's not as poor, is barely contracting and hypertrophied, and fractional area change was reduced as well, was 19%. And TAPSI was also 5 millimeters. So both RV and LV have had a impaired function. Assessing for the pulmonary vascular resistance here, when I looked at short axis view here, look, there's some mild septal flattening. I think, but keep in mind this baby's systolic blood pressure was 100, above 100. So the septal flattening is controlled by the difference between systemic blood pressure and the pulmonary pressure. So the LV extrinsic index was not significantly abnormal, but still there's evidence there's some septal flattening here, and the RV is dilated and not contracting. Here, the pulmonary vascular resistance index was also low. As you can see here, pulmonary acceleration time was 30 milliseconds, and the index was low, indicated that there is some sort of pulmonary or increased pulmonary vascular resistance. The duct was so small, is bidirectional as well as the PFO, but it's mainly left to right. So, and the pulmonaries, I don't know, my gain was not right, but the flow in both pulmonary arteries was normal. So we have now bidirectional shunts across the both shunts, the PFO and the duct, but there was no significant septal flattening. This means that the pulmonary pressure is significantly high, but is compensated by, not compensated, but because the systemic blood pressure is high, this means this is the cause that the septum is not significantly flattened in systole. So coming to the aorta, which I was worried about. I was worried about this part of this part. Is it coarctation or not? But when I did the flow, the pulse wave, not pulse, continuous wave Doppler, it was normal. And also the cardiology team were not worried about it. They said, that's fine, it looks like okay. So after I finished the echo, our radiologist came and did a bedside ultrasound to rule out renal artery stenosis, and there was no renal artery stenosis. Was a difficult one. The baby was not cooperative, and she had gaseous distension. So after finishing the echo and the ultrasound, she was mad, and she had significant metabolic acidosis. Her lactate was 15.8, and basics is -15, and her CO2 was 2.5. So just to summarize now, we have a late preterm baby who is self-ventilating in air, has sepsis or meningitis clinically, has systemic hypertension, she has heart failure, she has acute pulmonary hypertension and echo, and significant lactic acidosis. Okay, and there are things are not going with each other: hypertension with sepsis and heart failure. So what we should do next? Any suggestion? Okay, fine. So we had to intubate this baby, intubate and ventilate actually. The intubation, not because of respiratory reason, the intubation was because of to remove the stress on the heart, reduce preload and afterload to help the cardiac function. And so the baby was intubated, ventilated, sedated and paralyzed. So, and this is post-extubation, sorry, post-intubation X-ray. Anything? Anybody wants to comment on anything? You can write in the chat, please.
This is a very informal meeting, guys. Like, feel free to chip in or answer, or if you want, you can comment on the chats as well.
Mona, it's a 7 reps if you count it, so the lungs are not necessarily very well expanded. But just a comment, I don't think it's valuable at this stage. Okay. And a hard lung, hard heart, large heart, and probably time was on the top as well, or not it.
Yeah, great. Yes. I think I will leave. There's something else on the X-ray. I will leave it to later on. Okay, so I had to discuss with cardiology because for a couple of questions. The first one was about the structure. I was worried about the tricuspid valve and the narrowing at the aortic isthmus. And also I had a discussion what could be the best agent, because this baby was hypertensive at the same time, cardiac failure. So we suggested to start milrinone, and the baby was started milrinone, given to target so many factors, to target the systemic vascular resistance, reduce it, improve the pulmonary vascular resistance, improve the cardiac contractility. So many, this agent could target so many factors here. At the same time, we did a metabolic screen. All right, so now we started milrinone here, and this is the systolic blood pressure. And then after starting milrinone, the systolic blood pressure started to drop. Not very significantly, but started to drop. And I still see that the systolic blood pressure is within normal, or even not very compared to the diastolic. The diastolic is low compared to the systolic. So it's even here, the 25th centile, where her systolic is almost 95th centile. And after the intubation and the milrinone, the baby's numbers got better. So lactate has improved, and basics. She had a bicarb, half correction of bicarb here, that this here, but I think generally the baby's perfusion and they got better. All right, so the following day, of course, I came back following day to do an echo on her, and this is the apical view. So they can see in the cell, the heart is a bit happier compared to the day before. Still, but the new thing is I can see clearly now that the hypertrophy in both sides, and the right side also is still a bit dilated. If you look at the there is also intraventricular flow acceleration, sorry. So there is intraventricular flow acceleration in both ventricles here, indicating that there is bilateral ventricular hypertrophy. And on assessing the systolic function using the biplane-Simpson formula, ejection fraction was a bit better, although you can see it completely normal here, but when I calculated, it was 40%. On here, you can see now the ventricles are significantly hypertrophied, but there was no LVOT obstruction. I don't have the continuous wave Doppler here, but I have the pulse wave. There is no pressure gradient across the aortic valve. All right, so when we assess the PVR, the pulmonary acceleration time was a bit longer this time. It's not here actually, but the PVR index was a bit bigger, a bit higher, 0.2. Ideally normal, the pulmonary acceleration time to right ventricular ejection time should be around third. So there is some improvement compared to the day before. But now, you can see more septal flattening compared to the day before. This is probably because the blood pressure is lower now. So is compared to the day before. So now we can see the end-systole flattening, and LV extrinsic index was 2. The RV function is still impaired, but you can see still the trabeculation is not contracting that much. But the FSAE was a bit better than the day before. It's still abnormal. But yes, the day before was 19, and there's some improvement, 23 now. TAPS is still low, still around 5 millimeter. So still some improvement on the LV function. RV is improving, but is still not reached yet to the full improvement. Did you want to say something, Harsha? Hello?
Go on, Mona. Yeah, nothing more from my side. Yeah.
Okay, that's fine.
There are some comments on the chat. We can discuss that in the later. Yeah, that's fine. Yeah, go on. You carry on. Yeah.
Okay, that's fine. So the flow across both PFO and the duct was now like right to left. So yeah, so in summary about the echo, so biventricular hypertrophy with RV dilatation. So there was a moderate acute pulmonary hypertension. There was dysfunction, but the LV was a bit better than the RV. So day 4, the blood pressure stayed a bit high. So we had to increase milrinone dose to 0.66 micro kg per minute. And we discussed with the nephrology team, who said, you can start hydralazine if the blood pressure is not coming down. But I was with the hydralazine, actually, it was a bit twitchy because we have the systolic blood pressure was low. So my opinion at that time, so the blood pressure, the systolic blood pressure reflects the peripheral vascular resistance, systemic vascular resistance was low. If we give hydralazine, which is arterial, cause arterial dilatation, it may worsen the diastolic blood pressure and consequently the perfusion of the heart that is struggling already. So we did not start hydralazine. Eventually started labetalol, and labetalol we thought probably it has alpha and beta blocker effect, so it will help dilatation of the peripheral vascular resistance, at the same time reduce the cardiac contractility. And we investigated further for the hypertension. We sent urine catecholamine and serum metanephrine. So this was over the weekend. A few days later, so repeat echo again, the cardiac function is getting better, but still the RV is a bit dilated and hypertrophied, and there was no significant TR. This is with another 4-chamber view, showing how hypertrophied is the heart. The pulmonary vascular resistance was getting better. Now we have pulmonary exertion time is now 61 and almost 1/3 of the not yet actually 1/3, but it's much better compared to previously. We have still mild septal flattening here, not as bad as the second echo, and still we have a biventricular hypertrophy. I don't know. I felt that the RV cardiac function has got better, but when I calculate the FAC, it was a bit not normalized yet, 29%, and the TAPSI was not normal yet either. But when you see it, it's better, and the numbers have already got better. So now it's still biventricular hypertrophy with impaired. Is actually RV. We improved LV function, still impaired LV, but it's improving, and mild to moderate APHN. All right, so on day 9, she got, all the time she did not need high oxygen requirement or high setting on the ventilator. She was off sedation and paralysis, extubated to room air, and lines were taken off. And you can see, so this is the invasive blood pressure until here. Suddenly, when we took the lines out, did non-invasive, magically improved. I'm kidding. So I always do not believe in non-invasive pressure monitoring, but we cannot keep the UAC forever. The ultrasound the proper ultrasound was repeated on that day, and they found that Doppler assessment of the renal arteries, there appears to be a relatively slow systolic upstroke, indicating could be renal artery stenosis. On day 10, milrinone was stopped and baby continued on oral labetalol. So during our radiology meeting, our radiology consultant said, okay, this baby looks like she has skeletal dysplasia. And looked at the x-rays. So here looking at the shoulder joint here and the hip joint, both here, those are the previous x-rays. You can see something weird. Is that probably destruction, probably calcification? We are not sure. And there is a bit of here, if you like, probably some calcification here as well. And this artery, we're not sure. So we did a skeletal survey. And skeletal survey confirmed that. But it was a bit not easy case. So we have now 2 weeks old baby who is self-ventilating in room air, hypertensive, mainly systolic. She continued to be irritable on examination. Each time I touched her, she cried. limited extension of both elbows and knees. I remember in the last gens, the 5th gens, there was a lecture on a rare condition with it's probably some sort of rickets. So I don't remember, but exactly I remember there was hypercalcemia or calcification with hypertension. So I asked Mr. Google and gave me this. Could be generalized arterial calcification of infancy. They call it GACI. And on looking all the signs and symptoms of this condition, our baby had it. So this is the skeletal survey. Hello?
Yeah,
right,
I'm
so,
only, yeah, continue. Well, I think this appear, I think on my mind, the chat, she has put the same thing, like, she has written like, yeah, the bones on the shoulder looks weird. And Sujit also has written like, humeral edge looks abnormal. Yeah, I think you're talking about the same thing. I think they picked up on the first X-ray itself about the abnormalities.
Oh, great. Yes. Thank you.
No, sorry, this is Sujit's, my comment, well spotted. So he is the one who picked it. Yeah.
Yes. Yes, you're right. So the skeletal survey did not add that much to the previous X-rays. There's probably skeletal dysplasia, probably calcification. So what we did actually, where I went back and repeated the echo again. Sorry, I don't have ECG here now. And looked at the aorta. So the aorta looks very bright and non-pulsatile. And here as well, like the abdominal vessels, there's like some flow acceleration and some color disturbance. I did not Doppler it in the first echo because if there is no duct, I don't Doppler them. But on Dopplering them, you can see this upstroke systolic wave. I don't know. So, and it doesn't have the smooth one, the systole, and come down to diastole and have the diastolic phase. No, it didn't have. So, and also, but this was the abdominal vessel. I looked at the middle cerebral artery. There was no clear like brightness, and the Doppler was not showing the same finding on the abdominal vessels. So here the cardiac function seemed to be good. Qualitatively and quantitatively, I don't have the numbers here, but still there is biventricular hypertrophy, and this also still here on the long axis view. Fine, and so looking at now, you can see the short axis. You can see the septum is a bit convex now, and pulmonary acceleration time has normalized now. There's no evidence of pulmonary hypertension. So we sent.
Just 1 second. Plavin is asking, is there a myocardial calcification?
What did you ask? The
myocardial calcification.
I think this will come. Yes. There was myocardial calcification. So we sent genetics for GACI and R14. CT, we wanted a CT angiogram, but we struggled locally to organize that. Discussed with the endocrine team about GACI. They said, okay, it's probably look like that she has GACI. We tried to convince the subspecialty team, cardiology and renal or endocrine, to take her to do the CT. We struggled with that, but our amazing radiologist kindly helped us to do it. And there was diffuse arterial, this is the CT angio, diffuse arterial wall calcification or the annulus of the aortic valve, origin of both coronary arteries, aortic arch and its branches, and possible focal narrowing of the descending aorta, just distal to the origin of the left subclavian artery, the area I was worried about on the first echo. Also, the pulmonary trunk was calcified, and both pulmonary arteries, a hypoplastic abdominal aorta with diffuse arterial wall calcification of the abdominal aorta, origin of SMA and both renal artery, as well as both iliac and femoral artery bilaterally. And actually, the images were looked at Birmingham Children's Hospital, and they said there was mild atrial calcification. So this keeps with the picture is in keeping with the GACI. Her other investigations were unremarkable, as you can see. All the metanephrine, I don't know how to interpret renin. Only the BNP was a bit high, but she had cardiac hypertrophic cardiomyopathy, and other investigations were normal. Moved to BCH at 3 weeks of age, and a few days later, we got the confirmation of the presence of GACI, which in the presence of ENPP1 confirmed the diagnosis. After that, the baby started in bisphosphonate. Over there, she was more or less stable from cardiac and respiratory point of view. Blood pressure continued to be highish on labetalol. They were worried at some point about her tummy because of query bowel ischemia due to the narrowing of the abdominal vessels. Surprisingly, she had another episode of high CRP again over there. Was on meropenem, but all investigations were normal. And when I discussed with the endocrine team, they think probably it's part of the process, the inflammatory process of the condition. So we thought probably is not infection, is related to the condition. She at day 25, she was transferred to Manchester to participate in the Energy trial. Energy trial is a replacement. They will replace NNP enzyme replacement. She was progressing very well. She needed regular ORMO for significant pain and joint calcification. However, on day 45, she had a sudden cardiac arrest, and is likely to be from myocardial infarction secondary to coronary vessel calcification. Unfortunately, there was no post-mortem for that baby. So it's a very sad story. So I'll go now to talk about what is GACI. It's a rare autosomal recessive condition. It's characterized by calcifications of large and medium sized vessels, as well as extravascular parts. Has a high mortality rate within the first 6 months due to myocardial infarction. So only around 200 patients have been reported in literature. So this guy is interested. I think his all work is on GACI, and they calculated the predicted incidence of the condition to be 1 in 200,000 pregnancy. And they found that 67% of the condition is caused by an activation of ectonucleotide pyrophosphatase phosphodiesterase enzyme. And a small portion is caused by gene variation or activation of this gene. I don't know about this gene, but it causes GACI. So how does this work? So here we have the NNPP1. It degrades ATP to produce AMP and pyrophosphate. Pyrophosphate is very essential to keep the balance of calcium and phosphate and the calcification of the bones and prevention of the calcification of other organs. And if it is low, this means the phosphate is going to find the calcium, and they will join together and form hydroxyapatite that will be deposited in the vessels, causing the vascular calcification. Another issue, so the CD73, this enzyme, changes the AMP to adenosine, and the adenosine actually is essential for prevention of proliferation of the vasculature. So if we don't have AMP, we're not going to have adenosine. So these blood vessels will have proliferation of the intima and causing narrowing. Another pathology which it relates to later on, not in the neonatal period, the fibroblast growth factor is very essential to the balance of phosphate and calcium in the body. And its absence, it leads to release of phosphate or prevention of the reabsorption of the phosphate from the renal tubule, causing phosphaturia and hypophosphatemia, which eventually leads to rickets. yeah, this simply is the pathophysiology. It's very complicated than that, but I tried my best. So there are phenotypes. We have the infantile one, GACI, and there is another type. There are other two types, pseudo xanthoma elasticum. This is like calcification of the skin and the eye, and autosomal recessive hereditary rickets. So I'm going to talk about GACI today. So mortality rate is high as well due to myocardial infarction, heart failure, and the mortality is high in NNPP1 more than ABCC6 variant activation variant. Calcification decrease or resolve completely with time. Vascular stenosis persists into adulthood. So the mechanism by which calcification resolve is not understood, is not known. So the problem is, so that the Ferreira and the guy who has been working on this condition, so they looked at the clinical picture of, so 100% of the patients have arterial calcification, 90% have organ calcification, which includes heart, other organs, and joint calcification in 50% of the cases, mainly affecting the hip joint and other big joints. And when they looked at for example, the whole bar represent the whole group. 14 babies had aortic calcification. And however, 2/3 of them, at some point, the calcification resolved. And the black one, the section of the group that did not have calcification resolved. So yeah, our patient had, all of them had the major artery, big artery calcification, organ calcification, and joint calcification. So if you look at the overlap, so if babies with GAC survive the first 6 months, they may survive for a longer time, but they will develop hypophosphatemic rickets. But the mortality, as I said, is very high in the first 6 months. Treatment, bisphosphonate, should start within 7 days and can be given to mothers whose babies have antenatal diagnosis. It prevents calcification, but no effect on intimal proliferation. Sodium thiosulfate, it is a chelator for calcium. It has no effect on arterial narrowing as well, has a lot of side effects, and there is no published data. So the current hope now is the ENPP1 enzyme replacement. It was proven to be efficacious in animal models like mice and other animals. So currently we have I think it's a feasibility trial that looked at the safety and pharmacokinetic and pharmacodynamics of the enzyme, and is run by Inozyme company. It's a multinational study, mainly in the US. The only center here in the UK is in Manchester. Okay, fine. So there are few things I would like to address. From hemodynamic point of view, I didn't understand what's going on with this baby. So we will talk about the LV arterial uncoupling in GACI. So our patient had high systolic blood pressure and normal diastolic blood pressure. And normally, the diastolic blood pressure is pulmonary is the systemic vascular resistance mainly, and the volume. And this baby had calcification. So she should have had high diastolic blood pressure. And if the afterload was not high, in the sense that the diastolic blood pressure was normal, how did this baby develop hypertrophic cardiomyopathy? So I was not, I didn't understand what's going on. So, but actually, I tried to look for a reason, but actually this could mimic the cardiovascular disease associated with aging where they have stiff calcified arteries. So for example, we'll do some physiology here actually. So the heart normally pump and send a forward pulsed wave across and the wall of the aorta, and this this pulsed wave travels down to the peripheral arteries and then get reflected back to the heart and combines with the coming one, there are multiple of them, thousands of them, and reach to the heart during diastole, in the sense that when the aortic valve closes. So, come on. All right. So normally under normal condition, where we have a very soft, elastic blood vessels, so the heart will send this slow wave, go down in the aorta, peripheral vessels, then bounce back to reach to the heart. By the time it reached to the heart, the aortic valve is already closed. So, and that so increases the post-valvular pressure, improves and consequently improve the coronary perfusion. So this is the systolic wave, systolic part of it. Here, the aortic valve closes, and then it then is diastole starts. So it's reached here. So it helps to improve the coronary perfusion, because coronary perfusion happens during diastole. So, so what happens if it is a calcified artery? Come on. So when it's calcified artery, very stiff artery, what happens? So the speed of the wave here will be high. So the heart will send very speedy wave because it's moving in a very stiff artery, goes quickly down, goes back again to the heart. But at this point, it reaches to the heart during systole. So what happened? What does this do to the heart? So you will have higher stroke volume, will explains the higher systolic blood pressure, and this wave arrives in the late part of systole, not the early systole, creating, when it arrives late in the systole, the heart cannot handle that very much compared if this wave arrives and increase the load during early systole. So the heart to start to adapt and develops hypertrophy. So here we have, this is the diacritic note, that the wave has arrived here before actually the closure of the aortic valve. So now we have, when it arrives, it creates a very high load on the heart, and the heart has to adapt for that. So this explains why our baby had a high systolic blood pressure, normal diastolic blood pressure, and hypertrophy. I think this is explained in adults. I couldn't find any explanation in neonates or even children, because this, I think our babies had a bit of arteries of a very old person. Okay, so the other point I wanted to discuss was the heart-lung interaction. So when on day 2, when she was unwell, we had to, she had metabolic acidosis, and she had a has cardiac failure or a cardiac dysfunction. So we intubated this baby. Why did we intubate her? So normally, this can be explained by the heart-lung interaction. In a spontaneously breathing person, the LV, there will be the effect on the LV will be, so there will be negative pleural pressure, at the same time negative intracardiac pressure, but the negative pressure in the pleura will be more. This results in increase in the transmural pressure and the sum of it, leading to increase afterload. There will, because of the negative pressure, there will be reduction in the intrathoracic to extrathoracic arterial gradient, and there will be increase in the abdominal pressure, reduction in the LA pressure, and consequently increasing the venous return. So we have increased preload and increased afterload with just normal person. The same happened to the RV. There will be increase in transmural pressure, decrease in the RA pressure, and venous return. So what happens if we intubate a baby? So we intubated this baby for a reason. So when we intubate, where we are giving a positive pressure compared to the negative pressure the baby is having on spontaneous breathing. In this situation, we give positive pressure, increasing the pleural pressure compared to aortic. So the heart can pump the blood to the aorta with ease, reducing the transmural pressure, leading to reduction in the afterload. There will be increase in the intrathoracic to extrathoracic arterial gradient, leading to increase in the cardiac output, increase in the LA pressure, leading to reduction in the preload. So now we are reducing the preload relatively and reducing the afterload, so the heart can contract properly, reducing the preload because the heart is already dilated, and reducing the afterload, so the force the heart will need to push will be less. So we are trying to breathe for her to help her heart. The same happened with the RV. So it will be reduction in the preload, but there may be increase in the afterload based on the ventilation strategies we're using. If we're doing it right, there were reduction in the afterload. But if we have given a high PEEP or high MAP or under-recruiting the lungs, we may be increasing the afterload. So yes, I think after intubating the baby, her perfusion got better. At least lactate did not get worse, but of course the milrinone helped a lot. Okay, fine. So just in summary, just it's a bit, hypertension is not common in neonates, but I think it's under-recognized. GACI is a very rare condition resulting in generalized vascular and extravascular calcification. It has a poor outcome due to cardiac functions, but we're hoping that there will be some treatment in the future with the energy trial. And heart-lung interaction is very important in cardiac dysfunction when we look at them from that point of view. Also, LV arterial uncoupling, mimicking cardiovascular disease associated with aging. I think this is the only explanation I could have for from hemodynamic point of view for what happened to that baby. Thank you. Any question? Probably there are questions in the chat.
Thank you very much. Yeah, thank you. Very interesting case, excellent presentation. I really enjoyed all the literature review and also the animated video of the pulse wave across the artery. Yeah, very interesting, very easy to understand as well. Like, you know, see those animation. Excellent, thank you. Fine. I think yeah, there are a few questions. Okay, we'll go through it. Yeah, I think yeah, there's one comment by Mama. I think she's seen the case previously once, and the child presented with significant irritability. If you have any questions, you can raise your hand and you can ask the questions as well to Mona directly. Yeah, you can unmute yourself, raise your hand and ask the question. And there's a comment by Ajay.
Okay, thank you.
About the elasticity of the aorta allows systolic BP to not to rise as much as it would be if the heart is pumping to an inelastic aorta stiff. Do you want to comment on that?
So, sorry, say it again. I missed the part. Passage.
What Ajay is commenting is what his thought was the elasticity of the aorta allows systolic BP to not to rise as much as it would do if the heart is pumping to be on a stiff aorta.
I don't know, actually. I'm not sure, because I tried to find explanation to why the systolic blood pressure was significantly high and the diastolic was not high. But the only explanation I found was adult literature. And from the video I presented is actually because probably is not the volume we that goes down in the aorta. It's a wave. The wave comes down, goes back quickly during systole, increases the cardiac output. at the same time, it's a load on the heart. And this load led to the modulation and development of hypertrophy. I'm not sure about because normally when we have stiff arteries, we expect that the systolic blood pressure to be high, and the pulmonary vascular, the systemic vascular resistance will be high. I'm not sure this was not in the case, and persistently was normal systolic blood pressure. I'm not sure I answered that question.
Thank you. I have a question. We'll come to Sujit. Before that, I have a question. The images which you showed, the tricuspid valve, the first, I know you showed there's a Doppler was blood flow across, but the tricuspid valve movement was very minimal. Like I couldn't see any tricuspid valve. Was it because of the calcification of the tricuspid valve?
Yes, was the RA was calcified, including the valve, as per the report from Birmingham Children's Hospital. I was when I spoke to the cardiologist, I was with her. I called the consultant straight away, and I was with her while she's reviewing the images. Image number this, and because and she said, okay, that's fine, we can see flow, and she was not worried.
Because the tricuspid movement was really abnormal. Even mitral valve was quite abnormal, but tricuspid was like hardly it was moving in those images. So.
Yeah.
Fine, thank you. Okay, Sujit, yeah, question from Sujit. Yeah.
Hi, Mona. Thank you so much. Very interesting case. Like Harsha mentioned. Sorry, I missed the beginning bit, but I wanted to find out antenatally, was there any suspicion on scans?
No, actually, it was apparently was a low-risk pregnancy. There was no the antenatal scans were normal. The only finding is in the antenatal history is parents are consanguineous. They lost a baby in Pakistan. They in the neonatal period. They thought probably hypoplastic lung, but I thought probably the baby had the same condition because both parents are carrier of the condition, and another baby who had an encephaly and died and had termination of pregnancy, but the scans were normal. For this, it took us a while. Although it was not a long period, but still for this baby the time is critical because you need to start treatment as soon as the baby is delivered to prevent further calcification and death, although it may not help either. Yeah.
Going back and looking at your fetal medicine scans to see if we can see these changes, it may be worthwhile having a look just out of because for subsequent pregnancies may help. The other question I had is, the abdominal aorta image that you showed is very striking. And
which one of them? The first or the last?
One of that, the other case that came to mind is there recently was, not recently, a few months ago, Arvind had presented some data on growth-restricted premature infants, where because of the lack of elastin, you have these very sort of stiff aorta, and then you get this lack of Windkissel effect, and you get this really pulsatile flow going into renal vessels, which just exacerbates your hypertension. But I know here the calcification probably also was a reason.
I think this is confounded by the calcification and proliferation of the intima. It's not only calcification as well. So both of them. And so the calcification is weird because we don't see this in our population, even in pediatrics. We don't see them. So hemodynamic point of view, we don't know that much about it. Yeah.
Write it up.
Yeah. I'm waiting to meet parents actually to get the consent. Yeah.
So much.
You're welcome. Oh, Satish has his hand.
Hi, Mona. Nice to see you.
Nice to see you, Satish.
Very interesting case. I just wanted to share my experience. Many years ago, I had a similar baby who was transferred to us from one of the district general hospitals with antenatally diagnosed hydrops. And postnatal imaging, the striking feature was very first your echo, when I saw your echo images, that I had the memory of that case. Looking at the aorta and the pulmonary, especially your first echo images on the branch pulmonary arteries, you made a comment, oh, it looks bright. I think that's where I think the diagnosis was. And our case as well, had extensive investigations and eventually had the similar, diagnosis as yours. Sadly, she passed away. That baby was born at 33 weeks and high CRP. I think these all is kind of a syndrome, and the genetics were confirmed, GACI as well. I think it's under recognized. I think, like the previous colleague commented, I think clue might have been there in the fetal, if you look back on the fetal scans, because these walls of these vessels will be very bright in these affected babies. Obviously, now that we've got the genetic confirmation, parents of both are carriers, so I think you could test for the future pregnancies, I guess, isn't it? But yeah, well done and nice presentation. Thank you. I enjoyed thoroughly.
Thank you.
Any questions or comments from anyone? It's exactly 3 o'clock. Fine. Yeah, if there's no comments or questions, then we can close the meeting. Yeah, thanks, Mona. Thanks. Excellent presentation. A very, really interesting case and these nice images. And thanks everyone for joining. Thank you. So the next meeting will be 2 weeks from now. Okay, fine. Thank you. Thanks, everyone. Bye-bye.
Thank you. Bye.
Enjoy the rest of the day. Bye.